So as you look at my disclosure slide, I wanted to answer the question that was posed to Margie, because we actually tested it. There's a study in Journal of Clinical Psychiatry, I think. We did a randomized controlled trial of CBT to treat post-traumatic stress disorder in patients who had a heart attack. And a subsample was done through translation to Spanish. We made sure that we used phone service of professional translators, and it was a subsample, so it's not that robust. But what we found was this was less effective than the non-translation that we did. Same therapist, by the way, but better than the controls. Okay, so the next study that I'm now designing, I made sure that I have actually a therapist who's not just Spanish-speaking, Margie, but knows different dialects. So we covered that one. But so I would say it's best to speak in their mother tongue, but don't give up if you can't. It's still better than nothing, is what at least that study found. So anyhow, I was asked to talk something about treatment, but I knew Margie is going to talk about treatment, so I'm not going to talk about treatment. I'm going to try to review some mechanistic issues, because it's when you're thinking of treating somebody, it's not just important to understand what they have, which was the first talk that I gave, but what's the mechanism by which the bad outcomes happen, because then you can maybe have your treatment be more specific to, again, not just the diagnosis, but what happens because of the diagnosis. So this is more about what happens to people who have PTSD in medical setting. And this is really how I started, because when I started, people like Margie, or maybe Margie and herself, already published that this thing happens. This was not novel. But we didn't know much about what's the relationship between these symptoms and medical outcomes. And so that's what this talk is going to be about. I remember in my last talk I started with this fact that depression is, patients who had a heart attack and are depressed are doing much worse than those who had a heart attack and are not depressed. Why is that? And the corollary to this, if you treat depression, then you don't improve the outcome, you don't even improve depression. So what's different between depression and heart attack as opposed to depression without a heart attack? And of course, the answer is the heart attack is the difference. And the way you can think about it is there are biological consequences for sure, but the psychological issue is also true, and we should take that impact into account when we treat. And if we treat them like anybody else who has depression, don't be surprised that we don't do that well. Okay, and in fact, if you look at the fine print of a big study, SADHART, that was done, randomized controlled trial of the use of sertraline for the treatment of depression after cardiovascular event, what they found was, interestingly enough, the sertraline was not effective, but it was effective in a subgroup of those who had recurrent depression. So those who had depression before the cardiovascular event, meaning somebody was depressed regardless of the heart attack, it did work for them. So this really shows that you need to take the MI into account, and how do you do it? So let's talk about consequences of post-traumatic stress disorder or symptoms in general. Of course, there's psychiatric morbidity. PTSD in and of itself is something that you don't want to have, and it's stressful. That's why it's a psychiatric disorder. It also increases medical services utilization. People with PTSD use more medical services. This is well known. This is an area that I focused on, is that it is related to not taking the medications as prescribed or not following medical recommendations. And it also may be directly related to medical morbidity. Okay? So this is one of the first things. There's better studies than this. I'm just showing you. One of the first observations that we had, this is published, is that when we look at our emergency room, those who have PTSD, and I'm talking about PTSD, not PTSS, and whatever it is that they have in the ER, they had way more visits. Okay, so we looked at number of visits in the last 3 months. This is black is PTSD, gray is no PTSD. They also have something else. They didn't come for PTSD. Okay, they came from whatever medical reason was there. You see how those with no PTSD were the largest majority of just one visit. Those with PTSD had multiple visits. Okay, and this has been replicated and it's been shown. And then I was starting to think, and people here were talking about models, and I think that it's important that you have a model that guides your thinking. It's also important to think about the model and tweak it based on what you find. So you have PTSD here, you have poor medical outcomes. You know they're related, okay? But you don't know how. So at first I thought maybe like this. It just causes the poor medical outcome. And then maybe what happens is those who are having post-traumatic stress disorder don't take their medicines. We'll talk about why in a second. Because they don't take their medicines, the outcomes is not that good. Or they don't follow recommendations for that matter. It doesn't have to be, don't take their medicines. But then there's this guy here, depression. Where is this? Where is it floating exactly? So what people were thinking at the time is this is where depression is also causes poor medical outcomes. Well, it could be that it interacts with all of this. But what if it's this? If first they get stressed, they get the poor medical outcome, and the poor medical outcome causes them depression. Depression is the final pathway. If this were true, and if you treated depression here, you will do nothing to the outcome. If you treated this, you may improve the outcome. If you treated this, it doesn't matter. Okay? So let's talk about this, the relationship through non-adherence. Why would people with PTSD not follow medical recommendations? I have to say, it may be obvious to you now, but believe me, when I started, I remember I called you. I was at Soho, like in a restaurant, and you were in LA somewhere, and I said, well, maybe they won't take their medications, and there was like a silence, and she says, I've never heard that. So when we started, this was a new concept. And the reason is the avoidance symptoms. If you're trying to avoid thinking about your illness, and every time you take a medication, it reminds you that your illness, that you're sick, then you're not going to take the medicine because it reminds you of something you don't want to be reminded of. Okay? That's the mechanism. And of course, there are risk factors here that I didn't even show you before. So this is the model, if you would, the idea that some of our studies have evolved around to look at those elements to see, is that true, and other risk factors that are important. So the risk factors is another story. The risk factors can be associated with non-adherence. They can be associated with PTSD, as many people have shown here. They can also independently cause the poor outcomes, right? So PTSD, we know, develops in patients who have predisposing conditions. They're more likely to develop this. For example, a patient who has been already devastated by being abused and now has a medical illness, they may be less likely to cope well with the illness. You can be very concrete about it and say a child who was abused has a different relationship with authority figures, and then the doctor comes in, right? Children who have not been abused maybe they're more likely to think that the doctor actually is trying to help them. Children who have been abused, for them, adults are like bad people. And so why will all of us be different? Okay? So these are the few, and that's run very quick because I know you're very mindful of the time. Run through of some of the studies that we've done to look at those things. This was the first thing I've done in pediatrics, very small sample, but very specific hypothesis. And this was full PTSD symptoms. This was no diagnosis is the yellow, and red is partial PTSD, like PTSS. And we evaluated adherence based on a biomarker, and we found that PTSD, actual disorder, those patients were significantly more likely to not take their medicines, or significantly less likely to take their medicines. The other groups were fine. And then, of course, I didn't believe it, so I had to do another study, and that was with adults. I actually did not believe it until I did 3 studies that showed the same thing. This was a myocardial infarction patients. These are adults. They had an MI, they were discharged. We looked at captopril pill counts as a measure of adherence. 1 year after the MI, at 6 months, we did an assessment, and we looked at the incidence of severe adverse events. And we found that most of them did not have PTSD, as you would expect. Those who did were less adherent to the medications. And so I didn't believe that study because I thought the pill counts are not a good measure of adherence, so we almost repeated the same study, but we looked at thromboxane production in platelets in those patients because aspirin interferes with thromboxane production. All of them get aspirin after a heart attack. So if they produce thromboxane, that means they were taking their aspirin. If they don't, the opposite. If they produce, it means they weren't taking the aspirin. If they don't produce thromboxane, it means that they were not taking the aspirin. They were not doing what we told them. I think we published it in some papers, but this is what we found. This cohort has more PTSD, but still a minority. And what we found was about threshold PTSD symptom rates were much higher in the confirmed non-adherent group of patients. It's again quite significant. And remember, these are study after study with very clear primary outcomes, and so I believed it then. That actually, and the same study also looked, as I told you, about adverse events. This is just one of them. It worked for all of them. Cardiac admissions were much more common. This is a Kaplan-Meier curve, so less is worse. And you can see that the PTSD cohort, after a year, which was our cutoff for follow-up, did much worse in terms of cardiac admissions. Not surprising, because they also were not taking the aspirin and so on, and who knows what else they were doing, but you could see that this has real consequences. The fourth was I started to think about what are the risk factors, and we just did a retrospective chart review, but the result was so stunning that I didn't expect it. These are we had 3 cases of patients who actually died because of non-adherence. It was documented in the chart. These are transplant patients. They really must take their medicines. They don't take their medicines. They died. And we had matched controls. And what do you think was the most important risk factor? Anybody wants to shout out? Those who actually died. And then we did I'm not having the data here, but we did a prospective, because again, I didn't believe it. So we did a prospective study to look exactly at this risk factor, and it turned out to be right. The most important risk factor for death in transplant. Death because of non-adherence. Okay, nobody wants to risk their neck. It was child abuse. Okay, all of them. Okay, and this, again, this is a retrospective study. You should look at it as hypothesis generating, not as proof. But we have the proof, which I don't have here. You could look at it at the Orange Journal. We published it when we actually looked prospectively then on those who were abused in a larger cohort, and we found that they did much worse. Okay, so start asking about abuse. I don't know if it's common here or not in Israel, but we clearly had too many cases. Children are not the same as adults. As Rachel Yehuda, my other mentor, sometimes says, you know, children are not the same as small adults, but some adults behave like small children. So there's an issue with parental adherence. That's something we should all remember. Sometimes the parents' issue, that they don't give the medicine, right? And I actually start from everything we found, and we talked about it yesterday with Doron's group. I stop asking parents about children's symptoms unless I want the parents to tell me about themselves. I think that when a parent tells me that the child is nervous, what they mean is I'm nervous. But if I want to know the child's symptoms, I ask the child. So we saw that these symptoms are quite common. I showed you the numbers. I don't know if you followed me, but it was 15% or so, 10 to 20% of those patients have significant symptoms like this. And those symptoms are associated with poor outcomes, non-adherence to medications. And the question is what to do about it. And the first answer is I don't know, because we haven't done the study. We're trying to do it now, but I don't know. And the second answer, I really don't know. So I'm just now totally hypothesizing, but I think you need to be aware of those PTSD symptoms in the patient. Remember, last time I talked about in the parents. I think in the parents it's more complex. In the patient, it's bad news, okay, if it's above threshold. Only if it's above threshold, by the way, according to some of our studies. But you certainly should be aware of it. This is just my idea. Margie talked a little bit about, what do you say, beta blockers to prevent, that's an idiotic idea, but the thing is it was studied, is the point. There was somebody crazy enough to actually do a randomized controlled trial where they gave people beta blockers in the ER. Luckily it was adults, and it was shown not to help, so that's it. I think that giving medications for PTSD for children in our setting is not a good idea. I just think it, I don't know that, but the reason I think it, and you know there are medications that are approved for the treatment of PTSD in adults. Paxil, paroxetine, and sertraline are approved, FDA approved. The reason it's not a good idea is first, they're not approved for children, we don't know if they work. I was involved in one of the efforts to try to test it, and we couldn't. It was a pharma trial of 11 sites, and they just weren't able to recruit enough children. So parents are not stupid. Why would they have their children be treated for something like this? So we couldn't do that study, and nobody has. And the other issue is they don't take any medications anyhow. So you're going to give them another medication? That makes no sense to me. And I would assume that patients don't do what we tell them. I have now come to the realization it's a safer assumption than to assume that they do what we tell them. It's not always true. Some patients do what we tell them, but that's the minority. And so we should evaluate what do we do to reduce barriers for them doing what we ask them. In the United States, a big one is insurance. Here, it's not that, but I don't know what other barriers could be that stop the patients from doing what you tell them. I think that the usual exposure paradigm, the NAFOA's classic treatment, is actually working in this setting, and I don't just think, I did the study and it's published, and so I know now that CBT works in some of these settings at least. And it's safe. Interestingly enough, we published the only safety study of psychotherapy ever. Nobody's ever thought that it might not be safe. But I thought, because when I was giving talks, people say, I'm going to expose a patient, they're going to be really stressed by this treatment, and they're going to have another heart attack if they're... So I'm not ever doing it to somebody with cardiovascular illness. So we did that study. We did it specifically to patients with cardiovascular illness. We monitored their heart rate during the treatment, and we know it's safe now. It was hard to publish because when I sent it to the journal, the reviewers said, why are you showing non-significant p-values? I said, that's the point in safety studies, that there's no significant difference, that it's safe. Anyhow. But I think it should be tweaked. And the tweaking, and Margie spoke to this, allow for adjustment to a new reality. Those patients are not like classic PTSD patients. They are adjusting to a different situation. They really are sick, and most of the times they remain sick. I would say include others. That's a part of the community engagement, or things that you've heard about before. You should allow for post-traumatic growth. Some of the bad experiences actually make you more resilient. And don't forget about it. Don't pathologize everything, which is this, the next point. And that's it. Thank you to these people. I would like to, I've already said those, most of them. Here I would add Edna Foer was my mentor for the treatment studies. And patients and families who I did not thank to before, and now I'm thanking them because I'm showing studies that they volunteered to, and I hope were helped by. Thank you.
Thank you very much, Professor Shemesh. We have time for 2 questions. Yes, please.
You spoke about adherence, or rather the lack thereof. I would assume, maybe it's a stupid assumption, but I would assume that there's a difference between a child adhering to his own treatment plan or whatever, and a parent who is adhering for the child, because they're, in charge of the diet or making sure they take the pills, activity levels. I was just wondering in the studies if you guys differentiate between that, and if you see a difference between maybe ages or who's in charge of the adherence levels.
Yeah, I could give a whole talk about this. It's a great question. We looked at it. The last, it's a study you should look at. Where did we just publish it? Journal of Pediatrics, different cohort, where we looked at the relationship between. So we asked the child who's responsible for taking the medicine. We asked the parent separately who's responsible for taking the medicine. And then we looked at adherence 2 years later using a biomarker. And what do you think we find? When the adolescent, it's for adolescents, when the adolescent tells you, I'm cool, I can handle it, you should be worried. That's when they say, I'm responsible, outcomes are worse. Okay? When the parents say I'm responsible, outcomes were better. Now, the other thing was when the more discrepancy. It's all obvious in retrospect. When there's more discrepancy between what the child thinks they're responsible for and what the parent thinks the child or them are responsible for, then you also have trouble. So it's a very important construct. Many studies don't look at it. We looked at some of it in the studies that I show, but now there's a more robust study that is out, so you can look it up.
Yes, please.
Have you considered the possibility that perhaps PTSD and adherence and outcome are related to another factor, such as personality or socioeconomic situation?
First of all, we have considered it, and secondly, I'm sure that's right. The question of causality is a very interesting one, and association is not causality. But by now, we have enough data to show, A, that the symptoms precede the non-adherence, and B, that if you treat the symptoms, you improve adherence. So that's as strong as you can go with assuming that those symptoms really are causing. That does not mean that risk factors don't contribute both to the development of the symptoms and to non-adherence directly. It's just that, think about it differently. Suppose you have risk factors that are bad, like somebody has low socioeconomic support or something, and they are non-adherent. It is still possible that if you just treat the PTSD, they will become adherent. even though the risk factor is important and is still there, right? So our task as clinicians, in my view, is not to treat everything, but to treat the minimum we can, because we don't have unlimited resources, in order to get the good outcome. And that's the way we were thinking in our studies. But of course, those risks, as I think I've shown, are important.
Another short question?
Yes.
Last one.
Yeah, so, right, it gets dicey. What do you call abuse? We try to be very clean here. Those were only abuse cases that were reported to the Child Protective Agency. So in New York, what it means is was sexual or physical abuse. We did not look at neglect. We did not look at what we sometimes call medical abuse, and it is possible that those things are as important. But I wanted to see the issue is there's an issue with responder bias. In this case, if I ask somebody now, were you abused as a child, I'll get some results that are wrong. And we wanted contemporaneous documentation that this was reported to the authorities, investigated, and found that abuse. So this is a limitation of a study that we only looked at those egregious cases.
Okay, thank you very much again.